nearby. So the workup includes not only evaluating the bladder function, and potentially why or how the bladder could be making its urgency felt, but also the question is, are there other things in the pelvis that are tricking the brain into thinking it's a frequency, to tricking the brain into thinking it's something from the bladder? So those are two major places where you have to start to figure it out. And certainly in the setting of somebody with pain, pelvic pain, and dysfunction of bowel, of bladder, dysfunction of the uterus, dysfunction of any of the organs in there, again, my brain sadly goes immediately to, what could be common to this pain and dysfunction of bowel, bladder, etc. And you come down to something that's not directly bowel, not directly bladder, not GI, not urology, but actually GYN. And indeed, that's where the endometriosis very commonly comes into play. So that's the first bifurcation. Is it something with the bladder, or is it something outside the bladder, to sort of start the process of separating that differential out?
Now, Dr. Larish, you're a urologist, and so I'm sure it happens to you all the time that someone comes to you with pain and they think it's urological in origin, but it's really a bigger picture. How do you go through the things that could be wrong with that person?
That's a good question. So the most common scenario that I see in reproductive aged women, or reproductive aged people in general, is that they complain of, I get UTIs 20 times a year. And then we do a deep dive into their medical record, and we pull all of their urine cultures from the various urgent care centers, hospitals, primary care doctors, and we find that in fact they never had a urinary tract infection, that there was never a bacteria isolated. And that makes us take pause and say, well, if you never had a UTI, but you have UTI-like symptoms, urgency, frequency, waking up in the middle of the night to pee, feeling like you can't really hold it, feelings of incomplete emptying, burning with urination, stabbing pain with urination, electrical pain with urination, burning pain with urination, it sort of makes us think, is there something else going on? And then we sort of jump into the evaluation with the history. And what we really want to know is, do you fall into any of those categories? Do you wake up multiple times a night to urinate? Do you have urgency, meaning when you have to go, you have to go, and you know every Starbucks between point A and point B so that you can plan out your bathroom sort of stops along the way? Do you pee more often than your colleagues or friends or family? When you pee, do you feel like you empty completely? Do you feel like something's left behind? Do you ever have to sit down after getting up from peeing and go again? Those are sort of the big questions. And then if you answer positively to those types of questions, we start getting into more sensitive questions about pain with sex, pain with deep penetration, pain with external stimulation. Do you ever have leakage of or a gushing of fluid with orgasm? These sort of questions sort of lead us to understand, is there truly a bladder dysfunction that's going on in the background of whatever causative agent it is? When you start to piece together all of the clues, cyclical pain, being on birth control from a young age to control periods, having missed work or school because of your period, urinary symptoms, bladder symptoms, rectal symptoms, sexual symptoms, the picture of endometriosis comes together. And there's a very high overlap between patients who have bladder dysfunction, either in the background of endometriosis or coincidental to endometriosis.
Yeah, and Susan, as a physical therapist, how often somebody just comes to you and says they have pain? Where do and we don't have MRI and prescription pads and things, like, where do you begin with that?
So I loved what both of the physicians had just said in the way that they're looking at their differentials. Is it something within the bladder? Is it something on the outside of the bladder? And how does the picture come together? So when people come in and they're complaining of, generally the word is pelvic pain, or they'll be a little bit more sophisticated and say pelvic floor pain, or sometimes they'll just come in and say bladder pain. My questions are very much similar to theirs, but I'm looking at it more from a movement system perspective to see how much of the movement system is involved and how much of a contribution the movement system has with their pain, and how much of it is of a visceral component. How much, so if there's movement system contributions, there's things like, it's worse when I bend over, it's worse when I sit down, it's worse when I run, it's better when I walk. It can be, alleviated when I lay down. When I lay down, it's worse. So we can kind of look to see if there are mechanical drivers and mechanical, movement pieces that increase or decrease the sensitivity or the pain experience. And sometimes what we'll find is that there's components where it is mechanical, or the movement system as a big component, but it'll also have visceral ones too, which aren't going to respond to rest. In fact, they sometimes get worse when we quiet down. They get worse with either needing to go to the bathroom and urinate, or after they urinate, or during, like a lot of burning with. And then we go into the same questions too, vaginal penetration with a tampon, with a finger, with a partner, where is it on the, the beginning, is it deep inside? And also looking at things like having a bowel movement. Does the bowel movement increase the pain experience? Does it decrease it? Not having one, does that change the pain experience? And then we can kind of begin to tease out how much of that is a problem with the musculoskeletal system versus how much of a problem is with visceral sensitivity. And oftentimes people will come to me, they've been to maybe a few physicians, but they haven't been to the right one. And so being able to go through those questions and things like that can really help me kind of say, ooh, we need to get, a really good urologist or urogynecologist or gynecologist, whoever it may be that I know in the area on board to really help work through the visceral differentials with me.
Yeah, so I think we talk about differentials, and I'm sorry he's not here right now, because we have learned from Dr. Chung's work that oftentimes an inflamed bladder or pain driven by the bladder or bladder nerves, I don't like to go as far as saying interstitial cystitis because not everybody has that, but that bladder driven pain and endometriosis come together enough that we call them the evil twins of pelvic pain. And Dr. Vidali, how do you differentiate between what's bladder driven and what's something you can do a surgery about?
Well, I would like to first start with one point, which is whenever you're talking about the bladder, I think it's important to be systematic in your assessment, because I feel that unless the patient comes with a specific complaint about the bladder, walks in and says, my bladder, talks about the bladder, often it gets ignored. And I think that I would like to say the first thing that I think is important to be systematic in the anamnesis, in the history of the patient who presents with pain. And I don't believe that all physicians actually do this. I don't believe that all physicians, all doctors, it's part of physician education. I don't believe that all the doctors go through all the steps and look at all the systems and ask all the questions they should be asking. And certainly this is something that I observe that whenever, and I think Dr. Larish and Dr. Mackenzie and Susan Clinton can also talk about this. Is it Dr. Clinton? Sorry about that. I apologize.
Susan is fine. Thank you.
Sorry, I apologize. I just and Dr. Clinton, I think that all of you will know that sometimes you will ask the patient and mention the bladder, and they're like, oh yeah, of course, yes, I do get up 4 times at night. So I think that that's something very important that we should really emphasize, which is appropriate anamnesis, appropriate history taking has to be taken on the intake. And I think that this doesn't really happen. And I think that should have been mentioned. Now, coming to that, I would like to ask our panelists what they think of, this issue of comprehending really what the actual symptoms, bladder symptoms are. Because, of course, we have quite a bit of time to discuss this topic. And I think that, the frequency, the urgency, the retention, people think the retention means that your bladder is not working, but that it's actually not the case. Anybody want to comment on that, about the specific symptoms first?
Sure. If you think about the bladder, right, the bladder has two functions, and it has to do both jobs very well. It has a storage function, meaning it needs to distend appropriately. It needs to hold a large volume of urine, and it needs to not leak without your volition, without your desire to void. The other flip side of what the bladder needs to do, when you need to empty it, it needs to empty swiftly, efficiently, and without pain. And oftentimes when you have inflammation of the bladder itself, and by the way, inflammation of the bladder can be mucosal inflammation, meaning on the inside of the bladder, muscular inflammation or serosal inflammation, meaning on the outside of the bladder, or it can be inflammation of the nerves governing bladder function. All three of those sort of present differently, and the symptomatology that the patients present with are different. And to your point, Dr. Vidali, you and I have seen patients where we ask them, well, tell us a little bit about your story, and they complain of pelvic pain and period pain and pain with sex. And then we say, and how's your bladder? And they go, oh, my bladder's fine. My bladder's fine. And then you ask them, well, how often do you wake up at night? And they say 5 times. And you tell them, how many times do you urinate in a day? And they say, oh, about 20 times. Well, about once every 45 minutes. So the patient has normalized an abnormal dysfunction of the bladder because it's almost the least of their concerns. And yet, when we look at quality of life data on these patients, waking up in the middle of the night is one of the most disruptive indicators of quality of life erosion, so to speak.
How often, Susan, being a physical therapist, you get a full hour with that patient all the time. How often do you see people normalize their symptoms? Like, it's totally normal to pee 19 times after drinking a Diet Coke washed down with ketchup and tomato.
Yep. I've been this way my whole life. It's like I've always been constipated. It's not a problem for me. I've always been up 3 or 4 or 5 times a night going to the bathroom. Or ever since I had my kids, or ever since I started my periods. So there's always that element that I hear, this isn't really the issue that I'm here for the pain. And because it is normalized. I think that's the perfect word that Dr. Larish was talking about is, it's so easy for people to blow past those really important things that actually help us connect the dots to this bladder isn't functioning in an optimal way. It may be functioning okay for you, or you think it's okay, but it's not optimal. And that could be a driver of this experience, because pain is an experience, right? And there's many things that can add to the experience. And not realizing that the lack of sleep is driving the stress hormones in your body, which are increasing the inflammatory response of the tissues in and around the bladder that may be very sensitive to inflammatory markers. And really being able to draw those pictures together and to ask those deeper questions and spend time with them and really uncover that. Like you said, you mentioned the ketchup and tomatoes and the coffee and other things that, they can tell you that every time I do that, I not go every 45 minutes, I have to go every 15. Or, if I do this like right before bed, then I'm up, way more than 5 times a night, but not really relating to the fact that the exhaustion is what's feeding the stress and the threat, which for women is going to increase an overactivity response of the pelvic floor, which can be a muscular driver that can come in to be part of the pain experience around the bladder as well.
Connecting all the dots to extend that. one can think about it anatomically. Certainly a bladder is not in isolation. We don't just exist as a single bladder. Right next door to the bladder, just behind it, can be a very irritated uterus, and we'll call it adenomyosis in response to somebody's question. And likewise, there could be nearby, as Dr. Larish said, some irritated nerves because of endometriosis there. And so connecting all the dots between bowel and bladder and uterus and endometriosis and nerves really starts to broaden. And again, what you see across the panoply of not just the attendees, but all of us who are speaking, we're all representing different, we'll call it subspecialties. And the critical piece, sadly, in medicine is we don't connect dots. I don't talk to a urologist necessarily. I don't talk to a gastroenterologist necessarily. I don't talk necessarily to a physical therapist. So this effort to connect the dots falls down on the backs of the patients to start to make the connections across these, silos that we've constructed artificially within medicine, where everybody sort of exists within their own organ. And, I think the breakthrough for people who get endometriosis is that's the connecting. That's really the transition. And patients who bear the burden of endometriosis are bearing the burden of trying to pull what is a system of medicine that really is separated and doesn't communicate, so that the gastroenterologist says, well, it's not me. Bladderologist says, not me, because I don't see anything wrong, and it's not me, and it's not me. And ironically, it's the physical therapist that I'm seeing who say, wait a minute, I got the perspective here, and I deal with all these things. So I think this connecting the dots is a fascinating concept that, that's the critical piece to pull all this together. And we don't do it so well in medicine, but the patients do it really well in terms of making their own efforts and self-advocacy.
And I think there's value in the patient's story. If being quiet and really asking the questions to really get to their story, the dots, they're able to tell you everything and in a very meaningful way, but we have to allow them to give us that story and really listen to it.
So
Yeah.
I wonder, to our surgeons out there, what does it take to do really good endometriosis surgery so you can rule out that the pain is driven by the bladder? Because then we're going to talk about in a minute or so all the interesting stuff that can happen after excision. From a surgical perspective, we'll ask our surgeons, what does it take to do really good bladder surgery?
Dr. Mackenzie.
What does it take to do really good, quote, bladder?
To really do a good excision on the urinary system.
Yeah, said indelicately, it's getting rid of every last stinking bit of endometriosis. Because I don't know whether the lesion of endometriosis that's down near the uterus sacral is picking up what's called the hypogastric plexus, which has everything to do with bladder function. I don't know whether the endometriosis that's invasive into what the spinal root S234, which has everything to do with bladder function, whether that endometriosis is wreaking its havoc on the bladder system. I don't know whether it's the obvious stuff right on the backside of the bladder. But regardless, to really do a good, we'll call it treatment of bladder symptoms related to endometriosis, you have to get rid of all the endometriosis. And so I think that's it in a nutshell is, all the endometriosis, period. No ifs, ands, or buts. And that will, quote, remove that contribution provided by endometriosis to the whole symptom complex, particularly related to the bladder. But you're not done yet, because again, we now have this big uterus right in the backside. Met a patient today who was fine lying down where the uterus kind of tipped its way back away from the bladder. But as soon as she stood up and the bladder and the uterus resumed its normal position, here was this hot coal of adenomyosis irritated uterus now resting directly into the back of the bladder. And now she was fine, not up at night peeing, but during the day, she was every 45 minutes when she was standing. If she sat down and reclined a bit, she was better. She could last for a couple hours. So we have this hot endometriosis, quote, adenomyotic uterus that's right behind the bladder. And you're not done yet thinking about that, because again, pelvic floor muscles, when they are spasm, will trigger the brain into thinking that, oh, I gotta pee. I ran into a patient today who said, I'm not emptying. And I said, let me show you. You just peed and here's your empty bladder. Your bladder thinks it's empty. You're trying to force it to pee because you're getting a different signal from the pelvic floor muscles that are telling you your bladder's full. And this applies to the bowel as well. So the short answer is get rid of all the endometriosis, but then be aware of these additional stimulatory triggers that trick the brain into thinking the bladder's got to work and got to go.
And paradoxically, like you just said, like Dr. Mackenzie just said, the majority of patients who will have bladder pain will not have endometriosis on the bladder. They do not have endometriosis in the bladder. It's important to note that. So that's why it's important to remove endometriosis wherever it is, not just to look for it on the bladder. Although, Sally, I think, it's unfortunate that that Dr. Chung's not here tonight, because his perspective is kind of the opposite, right, Sally? He says, treat the bladder first and then worry about the endometriosis. We should say that, right?
I feel like I'm Maurice's disciple for a lot of years. But I want to say what Dr. Mackenzie was talking about, the nerves and the nerve roots, for our crowd that's out there. If you go to our YouTube channel and you go through our painful sex lecture, Dr. Chung goes through each and every nerve and how it innervates the bladder. And so that hypogastric, and how each nerve is connected as two. We're going to talk to Dr. Larish in a few minutes about spinal nerves and about sacral nerves. But that one of the things that Dr. Chung believes is that you can use the bladder as an access point. So you have to remember that if the person, first of all, if the person's coming to you and they're trying for fertility reasons and they're trying to get pregnant, if we manage their inflammation and we manage their pelvic pain so that they're able to have sex, then we may have managed their problem enough for them to get pregnant, right? If we're dealing with pain and they're not in any more pain, then we may have managed their problem enough, whether they have a uterus that's diseased, whether they, and so using that bladder as an access point and modulating the bladder and down regulating the bladder first is oftentimes a way, like an entryway. So I know that his original studies, of course, you do a good excision and you make sure it's a quality excision and you get everything you can. But you certainly don't start to go back in until you've really dealt with and started to think about the bladder. And so, Dr. Larish, at last year's Endo Summit, you talked a lot about aftershocks, and I just loved that term. Can you tell us a little bit about what you mean by aftershocks in the endometriosis pelvis?
Sure. I think of aftershocks in two different sort of, when I wear two different caps. One is with the preoperative cap and one is with our postoperative cap on. So in the preoperative cap, meaning in somebody who hasn't undergone surgery to remove all of the endometriosis, the aftershocks that I'm referring to are really sort of exactly that. They're little earthquakes of the bladder. And I think Dr. Mackenzie sort of alluded to it earlier when he said, your brain sort of is interpreting the pelvic floor as you needing to urinate. In reality, if your bladder is sort of twitching the way that, say, an eyelid can twitch, and you say, oh my gosh, my eyelid is twitching, that's very annoying. If that happens with your bladder, you feel like you need to pee, regardless and irrespective of how much volume is actually truly in the bladder, which is why people can sometimes sit down, pee, finish peeing, sit back down, and people are sometimes confused by the paucity or the very little amount of urine that comes out, despite the severe urge to pee. And so the aftershocks are sort of the bladder. It's almost like throwing a pebble into a pond, and that ripple effect comes through. And the bladder is one of the bystander organs that sort of will sense that. I also talk about aftershocks with respect to post-orgasmic bladder dysfunction. So in people who have an orgasm, sometimes that sets bladder spasms off. In the same way, you have this contracture of all of the pelvic floor, contracture of skeletal muscle, smooth muscle, descent of the pelvic floor. There's all these things that are happening, and then you can get aftershocks of the bladder sort of as the ripple effect from it. With respect to postoperative aftershocks, when you hit reset on the pelvis, and I think that's what good extraoperative endometriosis surgery, excision surgery is. When you get good surgery where you clean out all of the endometriosis, you are essentially hitting the reset button on the pelvis. It's not the only thing that hits the reset button. You still need physical therapy. You need biofeedback. Sometimes you need organ-specific work. But you're hitting the reset button. If you don't approach the pelvis as a conglomerate of multiple angles of attack working against the pelvis, if you think of endometriosis and pelvic pain as a linear sort of process, you really can't get ahead of it. It's a circular sort of thing. There are multiple organs that are, quote unquote, conspiring against you. And so when you hit reset by just dealing only with endometriosis, but not addressing the organ-specific problems, you get aftershocks. So we've seen patients that have horrific bladders and after surgery feel like $1 million. We've also seen patients who say, look, did I have a catheter in for my surgery because my bladder feels like it's on fire? And that's what I mean by aftershocks. There are other things that need to be addressed in the pelvis pre and post surgery to sort of avoid that earthquake of the pelvis.
Thank you, Dr. Larish. We have joining us Dr. Maurice Chung. For those of you that don't know, and I'm going to let him introduce himself for in just a minute. He's basically our co-host this season. He's been amazing. But Dr. Chung is the primary reason why anyone on this earth, certainly anyone on this panel and beyond, knows that the bladder and endometriosis are evil twins. He is the premier researcher in that field. And I wanted to just take a moment to let him introduce himself, but also Dr. Chung, why is it that the bladder can generate so much pelvic pain? You have to unmute, Dr. Chung.
Unmuted. Okay, is that good?
It's
so
awesome.
I'm sorry that I got in late because today the Wi-Fi things, I was trying to use the computer to log on, but I wasn't even able to log on with my computer, so I'm using my phone finally. I am a urogynecologist, MIS surgeon, dealt with endometriosis for 30 years and IC for 25, 30 years. And so basically, in the beginning of my career, what do I know? I only know endometriosis. Then I got to know more about the bladder pain syndrome and pudendal neuralgia and more with the muscles like pelvic tension myofascial syndrome. So why is it the bladder can generate such a perfect neural storm? Well, the bladder is innervated on the up higher by T10-11 on its own, and then the sacrum is S2, 3, and 4. But on top of that, these T10-11, S1, 2, 3, 4, they all talk to each other. So the bladder basically is the biggest organ in the pelvis. When you distend the bladder, the maximum capacity on a normal bladder should be over 1,000 cc's. So you think about what other organs you can put 1,000 cc's of volume in it in the pelvis. That's the bladder. So I agree with Dr. comment earlier about there are other things more than just the bladder, which is actually correct. ACOG in 2004, I suppose, talk about female pelvic pain, the quote non-cyclic. But I don't buy that. I think any female pelvic pain has a component of a bladder. it's up close to about 85% of it. Whether that is originate from the bladder or the bladder as a referral center, or the bladder is part of it. And there's two components of the bladder. The within the bladder and outside of the bladder. So that's a little bit different. And the funny thing is, even though when you examine the bladder, with patients have no bladder pain, and you examine the muscles, the pubococcygeus, the levator, the uterus, they hurt. But guess what? The bladder has something to do with it. Why do I know that? Because I follow my algorithm. I treat the bladder first and I re-examine the patient, even though the patient bladder was not tender. And when I re-examine the patient, there could be significant drop of the symptom of the levator ani muscles, and the pain's gone, or in different proportion, sometimes the right side, the left side, and sometimes the bladder could start out with 10, and I eliminate the pelvic floor muscle spasm and tenderness after I instill the bladder, and then left with the left side of the pelvic floor muscle, maybe a 2, and the pudendal nerve at the ischial spine, maybe a 2. And that patient have inherited pudendal neuralgia on the left side and the myofascial pain on the left side as its own. So there's so many things about the bladder. Either this is central sensitization, a referral organ, and to treat the bladder first is always my approach first, because it's easiest to treat in the office. Don't require any major stuff. And even though you treat it, the patient do so well, once you get into the surgery and you started to manipulate the uterus, which is, I call it mugging the bladder, left and right, up and down, put a catheter in, then you sensitize it again. And you do any excisional surgery and endometriosis on the bladder surface epithelium, then you sensitize the bladder again. So it happens a lot, even though I put the bladder at rest, and after endometriosis surgery, laparoscopy surgery, or even pelvic floor surgery, you pull a retractor, retract the bladder, and then you start over again. So I have definitely proved that the bladder is connected with the pelvic floor muscles, and in my study. And it may be through the vaginal mucosa. That part I don't know, but all I know is after I took care of the bladder pain right in front of my eyes, the myofascial pain was completely gone. So the bladder pain syndrome, or the painful bladder syndrome, it could be interstitial cystitis, it could be a refer pain, or actually it could be pudendal neuralgia. So I'll give you an example. When the bladder pain was about a 10, let's say 8, the pelvic floor muscle like pubococcygeus could be 8 on the right. The pudendal nerve could be 8 on the left side, could be a 6 and a 6. So after I treat the bladder, I numb it all up. The score on the right side drops some, the bladder drops some. It could drop from an 8 to a 6. The score drops some. But then once I give the pudendal block, all the pain went away. So now that particular case, the intravesical therapy, which treated the bladder urothelium, did not change the outcome. So on that particular patient, their problem is from pudendal nerve that go to the bladder tenderness and causing her to have urinary urgency, frequency, nocturia, incomplete emptying. Guess what? Post-void spasm. And many of these patients with pudendal neuralgia, they could have overactive bladder. And after sex, they leak urine. So that's my experience on the bladder, which is the biggest organ causing so much of the problem. I hope I answered enough, not too much.
No, we're so happy to have you. So I want to talk a little bit, and I'm sure Susan sees this as a physical therapist, but for sure, all of our surgeons see it, and I see it as a physical therapist. Patient has an excision with somebody they think is a decent excisionist, right? So hopefully the quality is pretty good. And they still have pain. So they decide, I need more surgery. And they start searching for another excisionist. But no one's dealt with the bladder yet. What do you do about that patient? Like, I get very frustrated. I had excision. I still have pain. I did 6 questionable pelvic PT sessions with somebody who was just like, I just went to anyone. And then, oh, since I still have pain, I'll take out my uterus. When is the point at which the doctors step in and say, let's treat your bladder?
Well, as I said, my approach has always been the bladder. And if the patient don't trust me, and I'll say, let's check it out. So they could come in with all the pain they have. I did all the pelvic floor mapping, starting from the perineal body, pubococcygeus, iliococcygeus, the ischial spine, sacrospinous ligament. Then I don't necessarily do the piriformis, because if the pudendal nerve hurt, the piriformis usually hurt. So why hurt them more? And then I'll go over to the bladder and then go to the other side. And I don't necessarily touch the uterus, because when you have all these points hurting so much, the uterus tend to hurt. But sometimes, if my finger is long enough, depends on how much muscle spasm, I reach over that spot. And surprisingly, sometimes the uterus doesn't hurt on the cervical motion tenderness. So the next step I usually do is, okay, well, if you look at the data, the most common problem in the pelvic pain, 85% have the bladder issue. So I'm just gonna do the bladder test right then and there, or have the patient come back the next week. So by putting I call the anesthetic challenge test, and within 10 minutes, I would go back and examine the patient. And then I get all the results right there. And if the anesthetic challenge test doesn't work, means that the symptom doesn't come right from within the bladder. It could be from pudendal nerve or the myofascial pain. Then I'll go ahead and give them pudendal blocks in the operating room. I do not do in office, because it's too painful. So then the patient knows, give me some time. I'm going to do your surgery. You already have 6. Well, of course, depends on who are the people operating on them. If somebody I know or somebody I don't. And depends on what I see on the operative report. So that's what I do. And the study shows it works that way. And that's how I convince the patient. I have not as yet have patient come in and ask me to do surgery when her pain's already better before the surgery. And now, of course, that there are still some patients would have some residual pain, then it could be the multiple surgery that she has. Then I have not examined the patient abdominal sites, such as the ilioinguinal, the genitofemoral, and they radiate down to the bladder. So when you examine the patient's bladder with the finger touching the bladder, it hurts. Well, in some of those patients, you give the ilioinguinal genitofemoral block, the bladder pain on the exam, it's disappear right in front of you. So what does that tell me? There are too many circuits, they're talking to each other. And the bladder is the major and biggest one. The pudendal nerve is not small, it's also one of the major one. The abdominal peripheral nerve sometimes also is a problem, especially for patients with C-section, previous laparoscopy, the trocar site injury. Those are one of those biggies. That's how I would approach it.
So, Dr. Larish and Susan, I'm going to ask you first, then I'm going to ask you, Dr. Larish. But what can you do as a physical therapist to kind of deal with that cross-talking that's going on between the nerves and the organs and the pelvic floor? Because a lot of what we do is an adjunct to something like what Dr. Chung does, but it's also a lot less invasive.
Mm-hmm. And the way he was describing it is beautiful. When you look at the anatomy and you look at all the nerves and you look at all the players, and the visceral and visceral somatic crosstalk is real. And there's many ways to begin to get people to deal with it, or to calm it down, or to have it not be so, the experience not be so large. And that's by with physical therapy, working with the movement system, working with the musculoskeletal system, and the myofascial component of the visceral somatic crosstalk, and the parts they can have. And I also love the way he identified and talked about the T11 T10 connection. It's not just the sacral connection, because there's so much we can do with as a PT, with breathing and with movement, and particularly rotation can have such a profound effect on changing, and desensitizing the nerves, from different parts of the body, that will begin to change it, at the area of where the it's being expressed as pain in the end, right? In the end area of the pelvic floor, the reproductive area, the bladder, the bowel. And, we have different techniques we can do that, can be right onto the tissue. I'm not a big poker and provocator of pain. I'm more of a, how can we get this to calm down? And what can we do to change it? And can we use ways to move, ways to breathe, ways to stretch, if you need to use that word, to begin to change length tension of the tissue? And can we begin to change the threat that the body is feeling? If the brain is under threat, the pelvic floor in females is going to react. That's just, we have really wonderful evidence on that. And so really playing the mind-body game a bit too is really, there's a reason why we want to go to mindfulness and things like that. It's not because we just want people to calm down. That is not the reason why I go there with people. I go there with people because there's a connection between our thoughts and feelings of threat and how our body responds. And we want to give the body the best chance it can to begin to have some more variance around the response, and not just one way to respond, as we see with that's a beautiful word, aftershocks, before and after, in the face of disease and in the face following surgical intervention. And that's exactly what that is. It's a response to threat.
Yes, and for everybody who wants to learn all about working with the thorax to make pelvic pain better, or working with the thorax because the thorax hurts, that is going to be Dr. Susan Clinton's specialty at this year's town meeting. So don't forget to buy your tickets, because it's not all about the Endo Summit Live. Dr. Larish, you work sometimes with devices that go on nerves. I know at Endo Summit Surgery, you're going to talk about Botox in the bladder. Can you talk about some of the ways that you work with dealing with the nerves in the pelvis and the bladder to help someone?
Yeah, thanks. So, when I think about bladder pain, I almost divorce myself from the etiology. Because ultimately, by the time you have significant bladder pain, the cause of it has to be dealt with, but that doesn't mean that the bladder pain goes away. It lingers. Mm-hmm. And so the initial causative agent isn't necessarily important. Keeping that in mind, the treatment armamentarium that we have to deal with the bladder is not dependent necessarily on the etiology, on what got us there. So one of the options that we have, even before interventions, is medication by mouth. The overactive bladder medications, for example, medications that work with central sensitization and desensitization, amitriptyline and the likes. In patients who have failed sort of local therapies, and there's somebody who one of our participants actually is on here, who's sort of at this stage. You know, you're not, just because you've taken oral medications and have had good endometriosis surgery doesn't mean that your bladder is going to be perfect. So, and nor are you end stage at that point. There are many other things that we can do. Botox for the bladder is one. Sacral neuromodulation, which is inserting a very fine acupuncture needle at the S3 sacral nerve root, or S2 or S4 sacral nerve root, and sort of like doing neurosurgery with the patient awake and you ask them to play a violin, you know, when the neurosurgeons are operating on the brain. We're not doing anything as complicated as that, but we have the patient awake, calm and feeling good, no pain, but we can actually stimulate the S2, S3, and S4 sacral nerve roots with the patient awake. And we can see, some patients will tell you, whoa, whatever you just did, that's it. That's it. And we basically leverage something called neuroplasticity, which is the brain tuning in or tuning out information. If you have a painful stimulus and you can get your brain to stop paying attention to it and pay attention to something else, that painful stimulus drops out. That's the whole concept of sacral neuromodulation in the context of pain. Although it also has some corollaries to overactive bladder. Botox works differently. Botox is working specifically at the level of the muscle to stop spasm. Sacral neuromodulation works ultimately at the level of the muscle, but via the nerve roots. And so there are different ways to approach this. I don't know if I'm answering your question. I feel like I'm rambling a little bit, so I'm going to stop.
It's Monday. We're all just working on it. Dr. Vidali had a question for Dr. Mackenzie. Go ahead, Dr. Vidali.
Dr. Mackenzie, excision of bladder endometriosis, right? You know, it's a big dilemma because obviously it's a radical procedure, but it has to be done. How do you approach that? If you're excising a large lesion on the bladder, what is your surgical approach with that? Because, you know, of course, we are endometriosis focused, and it's important we have a lot of patients who have this type of problem.
I think the approach for endometriosis involving the bladder sort of starts with the question, is it just on the backside surface, on the outside? Is it invasive into the muscle, or is it invasive through the muscle? I'm not sure, in all honesty, that there is ultimately a surgical difference, so to speak, other than, again, you're getting rid of all the endometriosis. Leaving it by halves and hoping this part is the part that was giving the symptoms and not the part that you left is a bit of a naive thought. Really, the fullness of the excision it requires a curative intent. The curative intent implies getting rid of all the endometriosis. Otherwise, you're left with, Jesus, the symptoms that are still there, is that due to the fact that they live? So to get yourself out from underneath get the patient out from underneath that bind of whether there's the endometriosis residual is still there, the approach has to be to get rid of it. So now comes the different depths of the penetration. And as a gynecologist and not a urologist, I've watched with amazement the urologists do things on the bladder and say, oh, it'll heal fine. It'll heal fine. You go, what do you mean that's going to heal fine? That didn't look like it's going to, and it does. It's startling how forgiving a bladder is, at least to the urologist. I'm not sure the bladder is as forgiving to me. So therefore, my approach is the following. Excise the bladder. And the real skill set for any surgeon is, can you suture it together laparoscopically? And so now comes simply the simple process of closing that in 2, sometimes maybe at 3 layers, and then making the bladder, or allowing the bladder to heal up with some, we'll call it bladder rest. That is, you don't need to expand out to 1,000 cc's and empty out. You don't need to do your work of the bladder. We'll give you a rest for a week. There's some people who say, don't bother, it'll be fine, says the urologist. I'm not sure exactly that a bladder will be as kind to me as it is to a urologist. So I put the bladder at rest for the week and give it a chance to heal up, and they do fine. But I think it starts from the curative intent of getting rid of all the endo out of that bladder. There are critically surgical areas where endometriosis gets into where the ureters come in, and that's a whole different thing where the care has to be that you that you work with the ureters and not disrupt how they enter into the bladder. And not that I do reimplants or anything like that, but that's where then that critical area of the bladder needs to be respected in terms of where the ureters come in. But in the main, the endometriosis over the years that I've dealt with is really coming in on the surface area on the backside of the bladder and not all the way down underneath the down underneath where the ureters come in. So
I can give you the perspective of a urologist whose bladders are not always kind to him. So I agree with you. The bladder has to be treated with respect, but it is a very forgiving organ if it's treated properly. I will say, and I love everything you said, Dr. Mackenzie, getting every stinking molecule of endometriosis out. I think I'm going to adopt that into my vernacular moving forward. I will say this, though. We have all made the commitment to be minimally invasive surgeons, I think, on this panel. The size of the incision is one part of that. Organ preservation is the other part of that. So we have to get every stinking molecule of endometriosis out, but we have to spare as much of the bladder in the process, spare the ureter in the process. And I think that's what you're alluding to. Dr. Vidali and I actually did a case within the last few months of a patient who had the endometriosis sort of coming in right underneath, right at the insertion of the ureter to the bladder. And in those cases, and it was a full thickness lesion. In those cases, we actually did a combined endoscopic and robotic resection approach where we outline from the bladder side. And what's really neat with today's technology is you can split screen. So you can do half the screen, almost like picture in picture. Half the screen is endoscopic view, meaning my view of the inside of the bladder. And the other side of the screen is looking intraperitoneally, basically looking at the outside of the bladder. What this allows you to do, it allows you to carve out the mucosal surface endoscopically through the bladder, separate, push all of that unhealthy mucosa away. And that actually allows you to do the robotic excision or the laparoscopic excision to a much more limited area where you're removing every stinking fleck of endometriosis, but at the same time, preserving maximal tissue so that you allow the bladder to regain its normal form and function.
Now, I believe the term is every stinking bit, because Dr. Mackenzie is one of my New Englanders and we say every stinking bit up there. So Dr. Chung has his hand up. Dr. Chung, did you have something to add?
Yeah, there are a couple of issues that, not issues, like comment I want to make. For the neuromodulation, S3 neuromodulation is actually really for the urinary urgency frequency. And if the pain gets better, it's a bonus. Because I've done it ever since 1999. And in the early phase, I've done so many of those. And when the patient feels better with the urgency, the pain goes away, that's wonderful. However, not forget, many of these patients have pudendal neuralgia, sacroiliitis. And anytime we try to irritate the sacrum and put an electrode in it, and then put a pacemaker in it, now the pacemaker is much smaller. It's like a thumb drive. And in the past, it's like a big matchbox. So many patients have secondary IPG site pain and need to be explanted. So that's the experience that I had before. I've done pudendal nerve neuromodulation, but then I come to the conclusion that I gotta get rid of the pain first before I would do the neuromodulation. That's my personal experience on that. As far as the bladder endometriosis, yes, we know there was a bladder endometriosis, but then it has to know how big of an incision. Well, I agree that you have to have through and through excision and primary closure, and just drain the bladder with the catheter for 7 days, depends on the location. Some area need to drain for a little bit longer. But let's not forget, the bigger the lesion, the smaller the bladder is going to end up with scar tissues. And of course, we got to worry about the primary closure, whether you need to mobilize the bladder of the uterine cervix, if there's a uterus there, so that you get much better closure. But there's another issue, is that patient, does she have a painful bladder syndrome to begin with? Like urinary urgency frequency, when the bladder fills up, the pain gets worse. So even though you could remove the endometriosis on the bladder with a through and through closure, but the patient would come back, they still have urinary urgency and frequency, and the original complaint, which was the painful bladder syndrome, interstitial cystitis, whatever you want to call that. And not forget about the pudendal nerve. If we don't treat them, even though you remove the bladder endometriosis, they could have residual issues. So those are my observation, my personal experience. Anything I want to add on that part? The bladder endometriosis, you have to excise it. There's no doubt about it. But it's very important to know the size, because I have done one probably close to about 4 centimeter diameter, and it's a difficult chore to suture them together. 4 centimeter big globs. So I do mark the area using indigo carmine on the abdominal side, and with the cystoscope looking into the bladder side. So I kind of know the area, and I don't have all this split screen and excellent robotic system in my place. I'm just using my old-fashioned laparoscopic, just cut the darn thing out. But then the closure is a problem with such a big defect. That's always a challenge. And sometimes you have to really drain it for like a good 21 days, because I have done a couple of those, and 14 days didn't even heal. It left me with a 5 millimeter gap. So I drained for 7 days, and thank God it healed. So again, don't forget about the painful bladder syndrome. The biggest help with that is the diet, spicy food, potassium, vinegar, coffee, chocolate, pizza sauce. All of those things can send the patient with endometriosis with bladder symptom off the roof.
You didn't leave anything. You didn't leave anything for them to eat.
No, I told them, stop eating all of them until you're better. Then you can add them back one at a time to see which one bother you. And lately, many of those patients have gluten problem. That is another bad no-no, because what else could they eat? They could not even get cornstarch, right?
Well, right. So
yeah.
Yes, Dr. Chung remembers having to travel with me and just eating a plate of eggs. Now I'm allergic to eggs. I couldn't even do that. So, so I just, before we talk about pain so much, but someone reminded me this evening that, you know, Dr. Vidali and I did a whole reproductive immunology conference. And I want to ask before, as one of our last questions, and then we'll sum up. Dr. Vidali, what is the impact of bladder inflammation on implantation?
Well, and we've discussed this before. It's the same rules that apply to any other inflammatory sort of cofactors in the process of implantation affect also, you know, reproductive, you know, it also come from the bladder, can also come from the bladder. This would be more of a factor regarding presence of endometriosis or recurrent, because they do exist, recurrent actual urinary tract infections. They are real. And in the process of working up for potential immunological recurrent pregnancy, loss of failed implantation, every single cofactor has to be ruled out. So your question is appropriate. Like, everything has to be considered whenever we're evaluating somebody who has a failed implantation, including bladder.
Right. So I just want to share with our panelists some of the comments that are going on Facebook. So first of all, there's at least 10 comments of this is more information than I've learned in 20 years of being sick. And most people are now saying they know more about how their pelvic floor and their nerve and their bladder works together than they've ever known before. So I feel really good about what we did here tonight. Lots of people are saying that they didn't understand the bladder was this much a driver of pain. So I feel really good that we're finally taking it to the people, because I think there are a lot of people here who have trained doctors for a long time, but now we're really training the patients to be able to get the help that they need. So let's talk about what's up next. Next week, we're talking pelvic pain with Dr. Mark Dassel. I think Dr. Chung is on the list. It's always his choice whether or not he wants to keep coming, because we love having him. And
I love to talk.
yeah, and I think we'll try to have Dr. Ahmed and maybe Dr. Shrikandi back, because they are our faculty, maybe Dr. Howell as well. Next week's all about pelvic pain. We will, Endometriosis Summit 2021 tickets are on sale. And it's very important that if you liked what you saw tonight, you get 3 full days in a custom platform, so not on Zoom. You'll be able to click on your fellow audience members and chat with them. You'll be able to ask your questions at the town meeting. Dr. Chung, Dr. Mackenzie, Dr. Vidali, and Dr. Larish will be joining us for our brand new Endo Summit surgery. Dr. Mackenzie will be talking about endometriosis through the reproductive lifespan, which I kind of hate that term, but that is the term. Dr. Chung and Dr. Larish will be doing bladder, and Dr. Vidali will be doing a live surgery that day, but he will also be discussing Pregimmune, which is an immunological measurement of your system for those seeking fertility. Susan Clinton, Dr. Susan Clinton will be joining us for the town meeting to discuss thoracic pain and thoracic endometriosis, along with Dr. Cernovo and Dr. Vidali. So we have a lot going on. We also have Endo Summit workshops. So we have 3 days, and you should go and get your tickets. And before we sign off, I'm going to have everybody tell me one thing they're looking forward to about the virtual Endo Summit. Dr. Larish, can you kick us off?
Yeah, I'm looking forward to collaborating with my peers and colleagues and actually being able to see this disease. I always see it through the lens of the practitioner. I think what this summit brings is the ability for us to see this through the lens of the patient, and that's what I'm looking forward to most.
Oh, yeah. And speaking of the patients and having a good time at the Endo Summit, we have just 1 or 2 more days left to buy your t-shirts, and you'll really want to wear your t-shirts for virtual Endo Summit in our virtual Endo photo booth. So don't miss out on that. Susan Clinton, what are you looking forward to the most about Endo Summit?
I'm looking forward to, as much like Dr. Larish, the collaboration of everybody involved, not just the practitioners, but the clients. And last year, I learned so much from the clients' families. I'm really looking forward to those stories and listening, the changes, the challenges, the celebrations that everybody has.
So in our recorded content this year, because you get access to 10 months of recorded content with the Endo Summit, Casey Berna, who is our Endo Summit social worker, she is working on recorded content called I Love Somebody with Endometriosis. And it's couples, and it's mothers and daughters, and it's also fathers and people who have endometriosis. And so that's a great way to get access to something like that. Mm-hmm. Dr. Mackenzie, one of my very first faculty members ever when we were just in a conference room at the Hoboken Hospital. Dr. Mackenzie, what are you looking forward to this year?
What I look forward to, I'll confess that I never knew about endo until starting to pay attention to what patients were saying and listening. I think, Susan, you mentioned the idea, if you just listen to the patients, they'll give you the answer. So why try and fight it and sort of come up with something different? So all my learning has been about endometriosis from my patients, teaching me the natural history. So once again, hearing what patients have to say about it, what they're learning about their own bodies, and therefore instructing me further. I think that's what I look forward to on each of these.
So I believe not all you're learning. Didn't you spend time learning from Dr. Redwine?
Yes, I went out for a week to watch what he was doing. I paid knowing what a failure I was in my own treatment of endometriosis early on, I sort of paid attention to what some people were doing throughout the country and decided to go out, make my pilgrimage out to Bend, Oregon, and was able to slide into his OR and watch what he did. And my first fright was when he turned his electrosurgical generator up to 100 watts cut and 50 watts coag. And I thought, good God, they're going to have a blackout in here in Bend, Oregon. But that was the breakthrough, was realizing how you leverage electrosurgical energy in a very elegant way.
So Dr. Redwine will join us both for Endo Summit surgery, and he's our keynote for the town meeting this year. And he's going to do a fireside chat with us and tell us all about sort of his tales from all his years in endometriosis. And if anybody doesn't realize this, we're allowing Dr. Redwine to be totally unscripted and unfiltered. So we have high expectations for him being able to finally say what he wants to say.
Your fireside chat is an apt word because of his use of electrosurgical energy.
Right. Well, we have him debating against Dr. Dan Martin in as part of Endo Summit surgery. Yes.
That's a good choice. Well, I'm just so happy to be here to listen to everybody else's experience. And I don't think I have anything else to add other than I just love to be in Orlando. So I'm thinking about heading down there.
So actually, Dr. Chung, I've been a little busy, so because a lot of you know what's going on, but we're going to go all virtual. There was an issue with going to Orlando because of COVID. We'll talk. We'll chat after.
I know I'm going there just for the fun, not for that.
Just for the fun.
Yeah,
so in May, we believe that Luminous will pick up their lab in Orlando. And we have partnered with them for that. And a lot of the people who buy tickets to this are going to be able to get access to their educational experience in May. It's in the works though. So Dr. Vidali, what are you looking forward to about the Endo Summit this year? Because it certainly isn't writing the checks.
Well, I'm looking forward to amazing content like we have every year. And I want to encourage whoever's watching today to get your tickets because look, we're not making, one thing I want to make sure, the Endometriosis Summit is not making money. Okay. We're not making money. We are, in fact, like I said before, we probably are losing money, but we're gaining knowledge. We love what we do. And we're trying to create a community and to build a community. So I really want to see this community grow. We have new practitioners, new doctors every year, new people, inclusiveness. And I think that our motto for this year is, reflects that, right, Sally? That's what we're trying to do.
It does. We've included many, many new faces. And our goal is just to have a conversation that's not driven by politics, that's not driven by pharma, where doctors get to express and patients get to express what's important to them, and everybody can have discourse together, because that's how you move forward. So we don't have people that come and point their finger and say, I'm right. It's always the uterus, don't even touch the bladder. We have people that come and debate, like, this is why I think this way, and this is how, and that's how we move forward. And it should be an entire 3 days of that, with a lot of patient engagement stuff and a lot of giveaways, and it should be lots of fun. So we hope you'll buy your tickets, and we look forward to seeing everybody who's going to be around next week. And thank you for joining us, everybody, this evening.
Thank you, Sally. Thank you, everybody.
Thank you, guys. Thanks, everybody.
Thank you,
Thank
everybody.
you.
All right.